as we know, you are a huge advocate and you are very high in demand that you even tutor other doctors as well. How do
Okay.
you find the time to do all that? It looks like you do so much when I read about you online.
Oh, well, we have a busy practice, but a lot of these things kind of fold in together. And, we put out educational content for patients and then other doctors see that as well. And then, we go to both Dr. Moling, my partner, and I, we go to at least two kind of big meetings a year, and we're always presenting information there. Like this November, I'm presenting a sciatic endometriosis case at AAGL. So we're always we video every surgery, so I'm always editing things up to either put online a little bit or to teach at a meeting and so forth. So it's just kind of part of doctorhood as far as I'm concerned. It's just sort of part of the deal.
I'm sorry, I didn't even introduce you, Dr.
It's okay.
Fogelson.
It's
You're from
Fogelson.
Oregon. Is that how you pronounce it? I'm sorry, I can't pronounce anything today.
It's Fogelson. Yeah, I grew up in Eugene, Oregon, home of the Oregon Ducks, and then went to medical school in Portland, and then ended up training in some different places, and then uh, I came back to Portland about 8 years ago and started my own practice. It was about 5 or 6 years ago. So
Wow,
here I
that's
am.
incredible. And you are one of a handful of doctors in the US that do, is it neuropelviology? Did I say that incorrectly too?
Yeah, that's correct. I think I'm the only level two certified neuropelviologist in the country. There's some other people that have done level one, so there's sort of different levels of training. Um, and there may be another level two that I'm not aware of. But neuropelviology is a specific study of pelvic neurofunction and neuroanatomy, and some of it is intellectual, of sort of a different way of thinking about pelvic pain that comes into play in diagnosis. And then there are definitely some surgical techniques that kind of dovetail off of that I'm able to offer that most patients don't. Or most doctors don't. Like I just mentioned, we did a sciatic endometriosis case a couple of weeks ago that I'm presenting at AGL in November, assuming they accept the video. I haven't heard yet, but the so definitely that's an area where I have a lot of interest and have a skill set that not everyone else has. So it's a good thing to be able to offer patients when it's appropriate.
Definitely. Out of the specialists I know here in Canada, the only one that I know that has that expertise is Dr.
Sure,
Limos
Lucilio,
at Women's
I know him
College.
well.
Yes, he's phenomenal. He's very well respected at Women's College. I remember he operated on me once, and the nurses said he was God's gift to women. They all loved him there, and they were so happy that he came from Brazil to come work in
Well, I'll tell
Canada.
you a funny story. After the International Neuropaleology meeting in Zurich some years ago, Nucelio and I were out kind of on the town, and we thought we'd get some McDonald's, and he went to get some chicken McNuggets and brought back 60 chicken McNuggets. And I was like, that's a lot of chicken McNuggets. He's like, yeah.
Well, between two men, I think maybe you guys could do it.
It's a little too much. It was just kind of funny. I was like, whoa, Nucelio, that's a lot of nuggets.
Well, we see that Americans have everything supersized compared to
This was in
Canadians. Like
Zurich,
all
though.
your
This was in
drinks, your
Zurich,
food,
but anyway,
everything's larger. Oh, true.
this was in Switzerland. Anyway, no,
Um,
yeah, Nucelio is a friend.
Oh, he's really great. He's really like empathetic and caring as a doctor. So I was really happy having him as my doctor.
Oh, fabulous.
But to wait for specialists here in Canada, sometimes we wait a year or longer, even 18
Yeah.
to 24 months for a specialist because we don't have enough of them. And there's just so many people that need that kind of care. So for anyone that wouldn't want to wait or felt like they're in too much pain that they could not wait that long, do you take Canadian patients? Would that be an option for them to come and see you?
Oh, yeah, we do. We definitely see Canadian patients. But, sometimes cost is a bit of a barrier, not so much my fees, but just the hospital fees. The good news is that we're actually partnering with a surgery center, and it's just about to take off where we're going to have a robot we do mostly robotic surgery, and we're going to have a robot available at the surgery center. So that will be a much reduced cost relative to hospital cases because when you look at doing major endometriosis surgery in the hospital, the hospital fees can be really quite substantial, 30, 40, $50,000 US, and it's just kind of exorbitant. Whereas the fees in the surgery center will be, just a fraction of that, at least 50% less, if not 70% less. And so that will be definitely more practical for more Canadian patients to come down and see us because otherwise it's just really so expensive. But I mean, we're always happy to do it, and certainly some people have come down and had hospital-based cases, and if cost is not too much of a barrier, of course, we're very happy to do that. And we see patients from all over the world. I mean, we have patients come in from seems like certainly all seven continents, including Antarctica, believe it or not. And
Wow.
I have a patient who lives about half her year in Antarctica, so she's kind of almost resides there. Um, but yeah, we see people from all over the place and are really happy to do that. We offer free consults, Zoom consults. Although I guess international patients, we do charge a nominal fee for international consults. But the we're happy to review cases and see if it makes sense to come and see us. And we have great scheduling staff that can kind of arrange a variety of things. And we have some contacts for hotels and that kind of stuff too. So we're certainly happy to do that. I know the Canadian system, it's a double side of the coin of the socialized healthcare system is really good in some ways, and some people in America absolutely want it. But then we see the other side of when you have kind of a supply limited system, where some people have to wait a long time to get care, and there's not necessarily as much of an incentive to create a lot of experts to provide care, and so it's a sort of a double-edged sword.
Yeah, it's definitely a very long wait. Sometimes if someone needs laparoscopic surgery, you could wait even 2 or 3 years just to have the surgery.
Yeah.
So, so it can be hard for some people waiting. And if they do have the option to go see other doctors, we like to try to help give them as much information as possible so that they know what all their choices are. Because I had to go to the US myself for care with Dr. Nishat in California.
Uh,
And the only regret I had was that I waited as long as I did. I waited a year of like deciding because of the cost if I should go or not. But I am so glad I did go because it really improved my quality of life. And I want other Canadians to know that they don't have to suffer and just keep waiting, that there is something that we could do. Like there's the US, there's Mexico, there's UK, there's even Romania that we have doctors in our group that have advertised before for care and in Greece. So
wow.
we'd like to give everyone all their options of everywhere they
Yeah.
could travel for care.
There are a lot of good surgeons in Europe, absolutely, and costs can be less there. And I know there's a group that's been traveling down to Mexico from the U.S. and been doing some surgery. I'm not part of that group. I'm plenty busy where I'm at, so I haven't needed to travel around to get more patients. But nonetheless, I'm very happy to help, and we look forward to doing more Canadian patients once we have our surgery center set up, because that's going to allow us to take care of most cases in that setting.
That'd be amazing. Please let us know when that's up and running because that'd be great to
It'll
share with
be very
everyone.
soon, really on within the next month, so we're pretty much ready to go.
Oh, wow. I saw that you also have been like on podcasts. Do you have your own podcast or do you just join occasionally?
We do have our own podcast. In fact, I used to have a podcast called the Endometriosis Podcast, and I was doing it with Libby Hopton, who is another advocate. And then it kind of fizzled out, or we stopped doing it. But I recently relaunched it with Shanti Moling, who is my partner, and we recorded an episode last month, and we're going to record another episode tomorrow. So you should see those come out once a month. And they are literature reviews of recent papers, and then we talk about other topics in endometriosis, and probably going to have some patients come on to talk about patient stories, and should be good. We're already getting some traction on it, so that's certainly out there. It's just called the Endometriosis Podcast.
That's wonderful. Thank you. We're definitely going to share that and put that up there for patients to find. Um, we did happen to come across a video of you, I believe, on X, when you were sharing about how some doctors don't like to share information on social media and that you believe it is a good thing to share. And you really advocate for better endometriosis care and for more awareness. Do you think there's a way for patients to collaborate maybe with their specialists to help create more awareness or to do anything to bring attention to this cause?
Well, a lot of people do, just like you're doing yourself. I mean, I think that when patients have been ignored or have had a difficulty getting a good diagnosis over a long period of time, once they get the answer and once they actually get on the road to getting better, a lot of people become quite sort of uh, motivated to speak out and to tell others, and hopefully help others have a more accelerated path to getting better. And um, absolutely. I mean, I mostly it's driven by patients. I mean, anytime they want to involve me on any kind of stuff they're doing, I'm almost always going to say yes. But I don't push patients to do that. They just do it on their own. Um, I had one patient who was actually a newscaster in Portland who was local news anchor, and she ended up having me on. We had like a long segment on the show, and it was great. So, all kinds of opportunities pop up, and we certainly go for it whenever it comes up, as long as it's feasible.
Yeah, that's really great. You've done a lot of media appearances, and that helps out big time. So do films like Below the Belt, I believe, but
Yeah.
it can be hard to access them. So sometimes we feel like the only people that might be watching them are the endo sufferers themselves because we're the ones looking for it. Where the public, it can be a little bit more difficult for them to
I think
find.
so. Like it doesn't really I don't think it gets screened to the general public too much. I mean, maybe in some school situations, but yeah, mostly it is a preaching to the choir.
Yeah. Do you think films like that do anything to help move the needle socially or policy wise?
I think
Or is it more of a support thing for patients?
well, I think it's both. I mean, I think that certainly the first Endo What, the first movie really brought a lot of people in. It certainly raised the profile of some of the surgeons that were on there as well. Um, and I think that it was it's good. I mean, I think it is good. I mean, after Endo What, Shannon Cohn then spoke before Congress or before the House in the U.S. and you know Warren and Orrin Hatch, which was amazing. You don't normally see Republicans and Democrats working together, but they ended up coming together and writing a bill to try to support endometriosis research, which probably Trump's thrown away by now. Um, but that was, I think that was spurred on by Endo What because I think Endo What got screened for some members of Congress that wanted to see it, and that may have led to that bill. So, yeah, I mean, I think all advocacy comes from so many different angles. So, I mean, clearly, Shannon Cohn created a really powerful piece in both Endo What and Below the Belt, and has motivated a lot of people. And it
Definitely. I
provides
found it very
support. It
moving.
provides support too. Yeah.
Yeah, it helps build the community a little bit stronger. It helps bring us together. We've had special events. I know the Endometriosis Network has done screenings in Toronto during Endo Awareness Month, and we're doing our virtual one because we are a virtual support group. So it will be available to anybody in any country between the weekend of June 7 and 8. So we're
Cool.
excited to air that. Endo
Is
What
there
was incredible. Awesome. So just maybe one or two more questions, if
Sure,
you don't mind. Since you take
sure.
Canadian patients, as a mother, do you take children as well? Because I know some doctors prefer not to take children, and some specialize only in children's gynecology.
So, I mean, I'm not a pediatric gynecologist, or adolescent gynecologist, but when it comes to endo, it doesn't really matter. I mean, anybody who's like, do I take those patients for surgery? Yes, sometimes, but it depends on the case. Like, I wouldn't say that. I think that from a medical point of view, that operating on 15 and 14-year-olds often leads to disappointing outcomes. And the reason why I say that is that you are operating at a time when usually they are still developing new endometriosis lesions at a fairly fast rate, and that usually you get a period of improvement after those surgeries, but you rarely get the kind of improvement that you're going to get after a patient who you operate on who's 25 or 30 years old. Now, on one hand, you look at that and you say, well, it would be better to wait and try to suppress the disease with medications, birth control pills, progesterone, whatever, and try to just get them through and have them, have success in college and whatever they're doing, and then maybe operate on them later. But there are also patients who are just miserable and they're not getting better with other things, and we can get them to be have a significantly improved quality of life for a period of years. I just say that with the caveat that if we operate on an 18-year-old, the likelihood they're going to have another surgery down the road is high, and it doesn't really matter how good you are. Like I think when you have a 28-year-old that has a bunch of deep infiltrating endometriosis, your outcome is very dependent on the surgeon being good at doing that. But you can be the best surgeon in the world and operate on a 16-year-old and remove everything that you can see, and you're still going to have a high rate of recurrence because it's just the nature of the disease state at that age. Um, but and that's my opinion. Patrick Young, who's published, he I guess has a different opinion, but that's not his opinion of eradicating disease in 16-year-olds has not been consistent with my clinical experience at all. And I'm not sure that it is real. But I think was opinion is real, but I'm not sure that is reality. Um, and but I mean, from a point of view of do I see adolescents? Absolutely. But you have to go through the case and discuss it and see if it's the right thing to do.
With the Canadian doctors that we have spoken to here, we've had some mixed opinions on this matter when it comes to children. But do you believe that it's possible for them to show signs or symptoms of endometriosis even before menstruation begins?
For menstruation, I doubt it. I mean, is it possible? I guess so. But I mean, that would be talking about 8 and 10-year-olds or something like that. And so, or 11-year-olds. That's not a patient population I work with at all. We would expect that most likely kids with endometriosis that they will go on to expressive endometriosis probably have some lesions present prior to menarche, but I would not expect them to have symptoms from that at that point. And certainly there wouldn't be anything to do about it, I don't think, if they did.
Okay, that's really good to know. Thank you. So we're really excited that your center is going to be opening up in about a month. And we know that in New York, there's also that research center that was just announced that they're
Yeah,
going to be building.
Tamara Seshkin's group is doing that. So that's great.
Mhm. Yep. And in Australia, we've heard that there is a $50 million donation to build an endo center there as well. So
Wow.
there's a lot of good things happening around the world. Is there anything that seems the most meaningful to you, or any research that has happened recently that stands out to you that you would think would be meaningful?
Well, I mean, there's a lot of basic science going on, looking at genetic origins of endometriosis, which I think is really interesting. Um, we're getting to know better what are the gene mutations that cause endo, and finding out that it's a lot of different types of gene mutations that are not all one thing, leading us to know that endo is probably many different diseases. Just like cancer is not just one disease, endo is probably not one disease. But there will be better understanding of the genetic origins of endometriosis, and that may lead to non-invasive treatments that really address the fundamental issue going on, or allow one to do surgery and then either maybe treat someone when they're young so they don't develop problems, or potentially more effective surgery. So there's a lot of interesting things on the horizon with that. There are also some other medications that are in trial. I think we've kind of beat a dead horse with like hormonal manipulation. There are a lot of drugs out there that suppress estrogen, or use progesterone to suppress lesions, and then new things come out that are basically the same thing. So they keep coming out with those. But then there are other medications that are in research levels for treating endometriosis that may work. I mean, we don't know. I mean, there's some stuff looking at angiogenesis in endometriosis lesions and possibly blocking that and reducing endometriosis lesion growth. But we'll have to see. All those drugs come out and they're excruciatingly expensive at first, and then if they work, and then at some point down the road they become more accessible. But that'll be interesting. One of the things that I think is just really kind of been transformational in endo has just been advocacy and social media kind of leading the doctoring world to realize there's a demand. Like, I really feel like at one point there was a small number of doctors doing good endometriosis surgery, and a lot of doctors didn't really believe in it, and it was sort of looked at as a fringe thing. And you had enough patients coming together in social media and talking about it that then led doctors to notice that, to where now young physicians who are coming up in training are kind of aware that, hey, endometriosis surgery is a potential career pathway. And so more and more people who are training in not generally in general OBGYN, but people that are doing like minimally invasive surgery training are getting more and more exposed to complex endometriosis surgery. And if you go back 15 years ago, and you go to the AGL meeting, which is the gynecologic laparoscopy meeting, there's just a handful of videos on advanced endometriosis surgery. Now you go to AGL and it's like the endometriosis show. It's like every video is endometriosis. So in fact, there are people that complain that AGL has become all endometriosis. And so, like, we have seen a real transformation in kind of what is the view of endometriosis in the world and how important it is. And So not only is there more research, but we are also pushing the pipeline from below and creating more doctors that are going to be, not necessarily, I think not so many doctors are going to reach a really kind of like elite surgical level. It's still gonna, that's going to be a few that are really interested, but I think the floor of how good at least people who've done like minimally invasive surgery training are going to have a much higher floor on how good they are at operating on endo. And that may improve like things in Canada when part of why it takes so long to get a doctor is it's not that many people that really have substantial training. Whereas I think that you're going to see more and more people having a much higher floor of sort of how good they are at operating an endo. And so hopefully that improves access. Long
Yes, when
answer.
people just go to a normal gynecologist here instead of an endo specialist, they're often told things like pregnancy secure, things and or that it can't happen if you are young or a teenager.
Yeah. And that's what they're
So
trained. As frustrating and as disappointing as that is, doctors are generally want the best for their patients. They just don't. I mean, when I did general OBGYN, I didn't get taught correctly. I mean, my training was garbage. I mean, nobody, I was taught what the people that trained me thought, and so in general, general gynecologists don't get exposed to it. Like I didn't see any endometriosis surgery when I was a general OBGYN resident. And what I did was going in and what I did see was a couple of like pointless ablation surgeries that really did nothing. And not only that, but I was told that surgery doesn't work by the people that train me, you know? And so I think that in the ACOG in America, American College of OBGYN, they're kind of anti-endometriosis surgery. It's not, you have to get up into the higher societies like SRM and AGL before they're going, yeah, endometriosis surgery is something that's useful. And so you kind of have to get through that beginning of like general residents, they are associated with ACOG or whatever the RCOG, the Royal Canadian version of that is. And I think you have to kind of get through that general group of people that don't really think endometriosis is very important and sort of get into more specialized societies that open their eyes to some different way of looking at it.
it's partly why it means so much to everyone that you're not just advocating and helping patients, but you are also out there training other doctors and kind of spreading the word about endometriosis and teaching them to be better surgeons so that even more people in more areas can get help. So thank you so much for that.
Yeah. And the thing that's really changed the world too is YouTube. I mean, like it used to be that you have to go to a meeting and watch a video and maybe get some mentorship from very hard to get mentorship, where all surgery is done laparoscopically now and almost all surgery, and then all can be recorded. So when people put video, even on Instagram, but also they put video on YouTube, you could watch surgeons operate and you can learn how to do stuff because if you learn basic surgical technique and then you watch other people operate, you can then go and do that. You don't necessarily need to have someone in the operating room like holding you by the hand how to do it. Like you can learn and replicate what you see. And so that's been very transformational in endometriosis, to be honest.
It's amazing. I'm sure you're a huge resource for lots of doctors that are learning. They're
Try
very
to be.
lucky to have you. Well,
Well,
did you have a mentor that helped lead you into choosing endometriosis? I'm
I
sorry,
mean,
I'm
not
asking too
really.
many
Well,
questions.
a little bit. I sort of. I mean, when I was a resident, I actually worked with a guy named Paul Underwood, who was an oncologist. And I remember we were doing a case that was supposed to be an ovarian cancer, and we go in and it's stage 4 endometriosis. And most of the attendings would have just closed up shop and said, okay, we're done, closed because there's nothing to do. Where he led me through doing this big endometriosis surgery. So he was an unusual guy, but he was a cancer surgeon. And the person had endometriosis invading into his colon. And he was this old Southern dude who's like, okay, go ahead and cut that out. And I'm like, you want me to cut a hole in her colon? It's like, yeah, cut it out. I'm like, she'll die. What do you mean cut a hole in her colon? And he's like, if you don't do it, I will. And so, I did the surgery and my eyeballs bugging out of like, I can't believe we're doing this. We're intentionally cutting a hole in this woman's colon. And then we repaired it and everything, and she did well. And I was like, oh wow, that was something I didn't expect. And so, um, that exposed me. That was the first time I'd ever been exposed to like the ideas of what you might do in complex endometriosis surgery. And he didn't continue to mentor me at all, really. I mean, he just sort of opened my eyes to it. I was mentored in how to do surgery in my fellowship. I did a fellowship in oncology. It wasn't a it was an oncology fellowship at Emory, but it's not technically an oncology fellowship. It was sort of an advanced pelvic surgery fellowship, but we did oncology, what I did. And that really taught me how to operate. I mean, it gave me the building blocks of how to do complex surgery and how to do bowel resections and how to do like really detailed anatomical dissections, which general OBGYNs are taught cookbook surgery, like how to the steps of doing a hysterectomy. They're usually not taught like complex anatomy and good complex surgical technique that leads you to have the building blocks to do more advanced things. And I learned those building blocks, and that's where I mentored with many people in my fellowship. And then after fellowship, I started the minimally invasive program at Emory, and I had great colleagues in nephrology and or urology and colorectal surgery, and continued to have support of people that could help me do really increasingly complicated surgeries, and trusted me to do this stuff, and they'd come in and help when need be, and that really provided a great floor for what I would eventually do. And then eventually kind of reached a point where I didn't need the support anymore. I just needed to continue to work and teach myself and watch video and so forth. But even like the stepping stone for anatomy for me was a video that I watched. This Indian surgeon named Shailesh Puntambaker. He put the video out in 2010, and it was a cadaveric dissection that just blew my mind. I never really understood anatomy like I understood it after watching that video, and I watched the video another 100 times. I got a copy of it. I ran up to him and I'm like, dude, you got to give me a copy of this video. It's amazing. And he gave it to me, and I watched it so many times. And it's kind of funny, like he didn't mentor me, yet he created this thing that transformed me as a surgeon. So that's kind of what I try to do, is try to pass on things that I've learned, and maybe someone will watch some video I made and said, oh, well, and that does happen. I have people come up to me that say that they watched something and they understood better how to do like a discoid bowel resection, for example, and then they went and did it. And I also just encourage people to not be so fearful. You know, when I see surgeons come up to me and says, well, how do you just like for a discoid bowel resection, don't you call general surgery? And I'm like, no, just do it. And I'm like, you know how to suture, you know how to use a scalpel, like, well, and then they call the general surgeon, and the general surgeon does it, and they go like, wow, I could have done that. I'm like, yeah, exactly. So you just don't call them, just do it. And um that sometimes it takes a little push for people to think about things a little bit differently, because I think people are trained to think of themselves as limited and think of themselves as being in kind of a little silo. And involving other surgeons is great and it's appropriate at times, but also understanding that being an advanced pelvic surgeon means understanding how to work with a lot of different things, not just like the narrow little silo of gynecology, because endometriosis is not necessarily just a gynecologic disease. It's a disease in the whole abdomen and pelvis. So understanding how to resect diaphragm, understanding how to resect bowel, understanding, and even if you involve a general surgeon in that, like understanding how to support them and what they're doing is an important part of having a good team. And so all that stuff kind of goes together.
Yeah, definitely. So it's great having this extra knowledge to put out there. So when patients do go see like a normal gynecologist and maybe are told something incorrectly, that they can learn that there is a higher level out there and what is false and what's correct, so that we can understand our bodies better and then make better choices for ourselves too.
Well, thanks for having me on. I actually got to go because the hospital's calling me about something. But
Okay. Well, thank you for
I
your time.
absolutely great to meet you, and certainly people can reach out. The practice is Northwest Endometriosis, nwendometriosis.com, and we're happy to consult with people. And again, our surgery center will be up and running soon. I mean, it's not our center, but it's a center that we're going to have privileges to operate at, and that's going to allow us to see international patients much more financially feasibly, or lower cost than before. So um, I think that will be more accessible in the near future. Really right away, we can start scheduling cases in the next few weeks. So we're happy to hear from people if they're interested in coming down.
That's amazing. We'll definitely provide a link to your office and to your podcast that you've been on so that people can find more information from you. So thank you so much for joining us today.
Awesome. Thanks very much. Bye-bye.
Thanks. Take care.
Okay.